Hello, my name is Arlene Gorelick and I'm the president of the Epilepsy Foundation of Michigan. And I would like to share with you a presentation from our conference, Wellness in Epilepsy. The presentation is entitled Pediatric Epilepsy, Improving Seizure Control and Quality of Life. The session is sponsored by Children's Hospital of Michigan. Our speaker today is Dr. Daniela Tapos. Dr. Tapos is a pediatric neurologist at Children's Hospital of Michigan and an assistant professor of pediatrics and neurology at Wayne State University. Her research and clinical interests include epilepsy, Tourette's syndrome, ADHD, headaches, and developmental delay. We hope you find this presentation beneficial, and please remember the Epilepsy Foundation of Michigan is here for you.
Thank you very much. Thank you for being here this Saturday morning, and thank you for the invitation. I'm glad to be here. My topic today will be pediatric epilepsy. Excuse me. Pediatric epilepsy, improving seizure control and quality of life. There will be some minor differences with your handouts. I have just added a few more illustrations into the presentation. Hopefully, it will not be a big problem to follow. The objectives of today's talk to review common pediatric epilepsy syndromes and new emerging therapies in childhood epilepsy, and to demonstrate the impact of treatment and behavior on health, school performance, long-term prognosis, and quality of life. We'll start with epidemiology. And we know that seizures and epilepsy affect approximately 2.3 million people in the United States. And this number is definitely bigger when you take into account families, friends, and work environments. There are approximately 181,000 new cases per year in the United States. Approximately 0.5 to 1% of US population is affected by epilepsy. By age 85, approximately 10% of the population will have experienced at least one unprovoked or acute symptomatic seizure, and 4% will have developed epilepsy. Comorbidities in the form of cognitive difficulties and depressed mood add to its burden. The annual cost to society is estimated to be $12.5 billion, of which 85% are indirect costs. We'll start with the definitions, Jackson's classic definition for epilepsy, which is the name for occasional excessive, rapid, and local discharge of gray matter. Now, the term local might not be always appropriate, as larger areas of brain might be involved in generation of the seizures, but that was a classic definition in 1931 by Jackson. Seizures are the hallmark of epilepsy. Epileptic seizure is a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. This is according to Fisher in 2005. By the definition of International League Against Epilepsy, epilepsy is defined as recurrent, unprovoked seizures. So a minimum of two seizures might define epilepsy, provided they are unprovoked. The list of causes is long. I introduce here a few slides with MRIs of some of our patients. The MRI is of a patient who has tuberous sclerosis, and we can appreciate the signal changes, the white discolorations on both hemispheres. The top is front for orientation, top is front, back is on the lower part of the screen, and your right is left and left is right for interpretation, but for orientation. But this is one of the causes of epilepsy in children. Neurocutaneous syndromes, among which tuberous sclerosis is an important cause. Cerebral cortical malformations, another patient who has semilobar prosencephaly, a midline defect, which is part of a long list of cortical malformations which can generate seizures. This baby had a stroke in utero affecting the right hemisphere, in a large area of the brain, and she's having symptomatic seizures as well. So the list for causes: cerebral malformations, hypoxic ischemic events, neurocutaneous syndromes, tuberous sclerosis, Sturge-Weber syndrome, neurofibromatosis, genetic causes, tumors, metabolic causes, and in a large number of patients, we are not able to identify what exactly the cause for seizures and epilepsy is. The diagnosis, it is based on clinical history and description of the events. However, we need to run tests for diagnosis purposes to help with identifying the location of the epileptiform activity, possible causes, and the impact of the seizures on the brain function. After history, physical examination and neurological examination brings in important tools for the physician to identify the cause and the source for the seizures. Electroencephalograms, the brainwave tests which we run, are a first diagnostic tool, and then neuroimaging such as MRI, which provides with anatomical imaging of the brain, and the PET scan, which provide a metabolic mapping of the brain, are also useful, and we are using them a lot for diagnosing. Conditions that can mimic seizures are, in early infants, breast-holding spells, shuddering attacks. The gastroesophageal reflux disease in infants as well can mimic paroxysmal spells, which can be confused with seizures. Sleep-related disorders, syncope, which is the passing out, migraine, movement disorder, tics and dystonia, strokes or transient ischemic attacks, non-epileptic psychogenic seizures are all conditions which sometimes are to be considered in establishing the diagnosis. According to the international seizure classifications, we have the focal or partial seizures which are generated locally, and they can be simple partial seizures with preservation of consciousness, complex partial seizures with impairment of consciousness, and both these types can generate and develop further into secondary generalization. Generalized type of seizures are absence seizures of or the staring spells, also known as petit mal seizures, myoclonic seizures, brief jerky movements of extremities involving usually the upper part of the body, clonic seizure, the rhythmic jerky movements of extremities which are part of the tonic-clonic seizures, tonic seizures, stiffening of the body, and atonic seizures or astatic, also known as drop attacks. What is an epilepsy syndrome? An epilepsy syndrome is an epileptic disorder characterized by similar features such as seizure type, precipitating factors, age of onset, etiology, neurologic and neuropsychological abnormalities, EEG findings, and neuroimaging findings. This is according to Engel in 2006. We review a few of the most common epilepsy syndromes in children briefly. West syndrome, which is sometimes used interchangeable with infantile spasms, actually presents with a classical triad. The children have developmental delay, they present with specific type of seizures, which are infantile spasms, and a specific type of pattern on EEG called hypsarrhythmia. The age group which is affected are infants. The incidence is 0.25 to 0.43%. Infantile spasms are specific type of seizures. They represent sudden, generally bilaterally symmetric contractions of the muscles of the neck, trunk, and extremities. Based on the muscles which are involved, they can be flexors or extensors. This type of seizures occurs in clusters. From few jerks to up to 100, every 5 to 30 seconds are included in a cluster of seizures. 60 to 85% of the patients might acquire developmental retardation if this type of seizures are not controlled. Subtle type of seizures delay the diagnosis, and in one study, 3.5 months have been the time of delay for diagnosing this type of seizures because they were subtle. The prognosis depends on what causes the spasms. 50 to 60% of patients develop Lennox-Gastaut Syndrome and other type of epilepsies. Treatment, first line of treatments are ACTH and vigabatrin. Other treatments have been used, steroids, topiramate, zonisamide, lamotrigine, and oftentimes we need to combine medications to control the seizures. Cryptogenic cases, which are epilepsy, epilepsy where we think that there is a cause, but we cannot identify the cause for the seizures, improve more than symptomatic ones. Symptomatic epilepsy is where there is a cause, it's identified, and it's most of the time related to cerebral malformations, strokes, or other abnormalities. The relapse rate after the ACTH, it's about 30%. With vigabatrin, in one study by Icardi, 68% suppression of spasms was attained in 4 days. Lennox-Gastaut syndrome, it's an intractable form of epilepsy. It features developmental delays, multiple seizure types such as atonic, generalized, tonic seizures, atypical absences. It has, again, a typical pattern on the EEG of slow spike and wave at less than 3 Hertz per second. Prognosis is guarded. The seizures are intractable, combination of drugs is often required, and the response is poor. Severe myoclonic epilepsy of infancy, known as Dravet syndrome, starts in infancy. Seizures are initially accompanied by fevers. They are oftentimes diagnosed at that time as febrile seizures. Later, the patients present with unprovoked seizures, which become more and more difficult to treat. Multiple types of seizures can occur: myoclonic seizures, generalized tonic-clonic, atypical absences. The children present with developmental delays. There are certain types of drugs for this particular genetic type of epilepsy which worsen the seizure. One is oxcarbamazepine and lamotrigine. The incidence of this disease is rare. It occurs in 1 to 20,000 up to 1 to 40,000 population. Generally speaking, the therapy is disappointing, seizures are intractable, and the outcome is poor. Genetic mutation in SCN1A gene, the alpha-1 subunit of the sodium channel mutation, is identified in some of these patients. Childhood absence epilepsy affects school-age children. It might represent 2 to 10% of the childhood epilepsies. The causes are genetic factors, features, normal development, children who are doing well in school, they present with these absence seizures, which can be multiple a day. They last briefly, 10 to 15 seconds, and there is no confusion afterwards. Freezing, inaction, and behavioral arrest is often described by the families. Prognosis is very good. It is treated with certain type of antiepileptic medication, etosaximide, valproic acid, lamotrigine. The typical EEG pattern for absence epilepsy is of what is described 3 Hertz spike and wave. One can appreciate the generalized pattern of this high amplitude spike and wave activity, which is lasting for a few seconds, then the EEG is normalizing again. Juvenile myoclonic epilepsy affects children in their teenage years. Genetic factors are involved. The seizures occur early in the morning. They present with brief jerky movements, myoclonic seizures. You might hear that the patient is dropping early in the morning the coffee cup or something they might hold, or the toothbrush. They also have generalized tonic-clonic seizures in approximately 85% of the patients. Long-term treatment is necessary due to the high rate of recurrence of seizures. Valproic acid, levetiracetam, and lamotrigine are medications which help in this type of seizures. Now, according to the location, different type of seizures might look differently. I chose to illustrate the temporal lobe epilepsy as it presents with complex partial seizures in a very classical way, with the description of the aura described as abdominal discomfort, nausea. The déjà vu phenomenon might be described by the patients. Lip smacking and other automatisms like swallowing can be seen, and they can progress to loss of consciousness. The 3 MRIs which are presented here identify different type of lesions all located in the temporal region and in the temporal region on the left side. This slide shows how neuroimaging is overlapping in identifying the cause for certain type of seizures. The MRI shows the focal cortical dysplasia, which is the developmental malformation of the brain in the area where the arrows are, and the PET scan, which we said that generates a metabolic mapping of the brain, shows this low intensity changes in the same region, which is generated by the hypometabolism of the tracer which was used, which is the glucose. Temporal lobe epilepsy. There is an excerpt here from a review article which says a randomized controlled trial of epilepsy surgery patients suggests that temporal lobe resections in those who are appropriate candidates for surgery offer greater freedom from disabling seizures and greater improvement in quality of life than chronic medical therapy alone. That is to illustrate that temporal lobe epilepsy is among the most amenable types of epilepsies for epilepsy surgery. Important information for families once they have to deal with this problem of the child having seizures. They need to be told the type of seizures. The epilepsy syndrome, whenever it's possible, is another information which it's important to be given. It has to do with the type of treatment, also with prognosis. Treatment options. The time frame for assessing response to therapy is an information which the families should request, and the need to consult with specialists if seizures are not controlled within 1 to 2 drugs. Managing risks. Status epilepticus is an epileptic seizure that is sufficiently prolonged and repeated at sufficiently brief intervals so as to produce an unvarying and enduring epileptic condition. Based on Gastaut in 1973. The duration was variably estimated for the seizures, for the status epilepticus. Generally accepted duration of time is 30 minutes. The mortality rate in adults, 6.6% to 17%. In children, 3%, with most deaths occurring between 1 and 4 years. Recurrence risk is variable. 4% in idiopathic type of epilepsies, where we do not know the cause. On the other hand, 88% of the recurrent status epilepticus are accounted by symptomatic epilepsy and patients with abnormal neurological signs. Neurological sequelae, in one study of 239 cases, 20% of the patients have been found to have this neurological sequelae. Hard to determine whether this was generated by the primary condition or the status epilepticus per se. Effective, faster treatments contribute to improvement in prognosis. Sudden unexpected death in epilepsy. It is known that patients with epilepsy are more prone to have sudden unexpected death. The most important epilepsy-related mode of death, it is the leading cause of death in people with chronic uncontrolled epilepsy. It actually represents sudden, unexpected, witnessed or unwitnessed, which is non-traumatic and no drowning cause of death for people with epilepsy, whether there is or there is not a proof for seizures. The incidence varies from 0.09 to 9 per 1,000 patient years. They tend to be associated with generalized tonic-clonic seizures. And the incidence of sudden death in epilepsy population exceeds the incidence of sudden death in general population about 24 times. Risk factors associated with SUDEP: young age at onset of epilepsy, long duration of epilepsy, poorly controlled seizures, and absence of treatment. Treatment, we're going to move into treatment with reviewing briefly antiepileptic medications, epilepsy surgery, vagus nerve stimulator, the Tapos stimulator, ketogenic diet, and other treatments. We call the drugs antiepileptic medication. They are probably more anticonvulsant medication, but for the rest of the talk, we're going to refer to them as AEDs. The goal of epilepsy treatment is to use the smallest amount of as few drugs as possible to control seizures. Now, choosing the medication for seizures can be complicated by factors such as age, the seizure type, the epilepsy syndrome, the presence of comorbid conditions, dosing, titration, side effects, and so on. We need to establish a realistic goal once we start the medication, and we are talking about old generation medications and new generation medications based on when they came on the market. Prior to 1990, 6 major antiepileptic drugs were available for the treatment of all forms of epilepsy, and those are carbamazepine, phenobarbital, phenytoin, primidone, valproic acid, and ethosuximide. About older antiepileptic medication, we know now that they have complicated and complex pharmacokinetics. Some of them are enzyme inducers, which complicate their metabolism. They speed up the clearance and metabolism of other drugs, and there are important drug interactions with commonly used medications. On the other hand, they tend to be broad-spectrum medications. They have lower costs. We know their efficacy, and they are widely available. The new antiepileptic medications approved after 1990s, early 1990s, gabapentin, lamotrigine, levetiracetam, topiramate, thiagabine, oxcarbamazepine, and zonisamide. This table presents the adverse reactions, different adverse reactions with the new antiepileptic medication. We'll go through a few. Gabapentin, weight gain, sedation, edema, behavioral changes. No serious adverse events. Lamotrigine, a serious side effect is rash, including Stevens-Johnson syndrome, where the risk is increased for children, reason for which the titration we use is very slow. The concomitant use of valproic acid is also a risk factor. Hypersensitivity reactions, arthritis, hepatic and renal failure are also listed in the serious adverse effects. Levetiracetam or Keppra does not have any serious side effects. On the other hand, irritability and behavior changes, mood changes are often reported by families. Oxcarbamazepine, hyponatremia with long time treatment, rashes in 10% of the patients. Topiramate, kidney stones, nephrolithiasis, open-angle glaucoma, hypohidrosis, the difficulties with sweating. Also, zonisamide linked to topiramate causes rashes, again, kidney stones, and hypohidrosis. About new anti-epileptic medications, we know that they are involved in less drug interactions, they have fewer side effects. But on the other hand, we have a relatively short-term experience. We are still identifying efficacy, tolerability, and safety in some instances, and the costs are higher. Now we have other therapies emerging in this field, and the newest anti-epileptic medications are as following. Lacosamide or Vimpat. It is an adjunctive therapy approved for the partial onset epilepsy of adolescents of 17 years and older people. The side effects have to do with dizziness, visual complaints, nausea, vomiting, fatigue, headaches, and depression. There are serious side effects listed, such as cardiac rhythm prolongation in patients with a heart condition or history of heart condition. The advantage of being present in different formulations, pills, liquid, and intravenous formulations, is there. Rafinamide or Banzel, adjunctive therapy approved to use for seizures associated with Lennox-Gastaut Syndrome for children older than 4 years and adults. The side effects listed are tiredness, difficulties with coordination, dizziness, problems with walking and movement. Clinical studies have shown reduction of seizures with 33% overall. Ezogabine or Potiga, approved in June 2011. It is an adjunctive therapy for refractory partial epilepsy in adults. It activates the neuronal potassium channels. The disadvantage of administering 3 times daily is there. Carbamazepine and phenytoin increases the clearance of this medication, and the side effects are related to CNS and the dose, somnolence, fatigue, dizziness. Vigabatrin or Sabril, approved in 2010, used for treatment of infantile spasm in infants and children 1 month to 2 years of age. It is also approved for adjunctive therapy for partial onset seizures. It increases the GABA by blocking its metabolism. It is metabolized through the kidneys and reduces the phenytoin level. Potential serious side effects are the peripheral vision reduction, for which the patients undergo periodic ophthalmological evaluations. We know that 2/3 of the patients with epilepsy will respond to treatment with 1 or 2 drugs. The work of Kwan and Brody defined the treatment-responsive and treatment-resistant type of epilepsies. And they show that first anti-epileptic medication used will control seizures in 47% of people with newly diagnosed epilepsy, and 13% more will become seizure-free with the second medication tried. So we have a 60% of patients which are controlled with the use of 2 drugs. 30 to 40% of patients continue to have seizures which are not adequately controlled by pharmacotherapy. Predictors of persistent seizures are still not completely understood. Certain epilepsy syndromes or seizures are more likely to become intractable and lead to adverse consequences and disability. We know that children with infantile spasms are more likely to develop Lennox-Gastaut syndrome. Patients with a symptomatic cause of seizures, such as head trauma, tumor, or infection, also are more likely to experience recurrent seizures. According to the World Health Organization, disability due to epilepsy accounts for 1% of the global burden of the disease. The number of surgical procedures performed in the US increased from 500 in 1985 to 1,500 in 1990 and continues to grow. Certain types of epilepsies, such as mesial temporal lobe sclerosis and neocortical epilepsy with easily resectable lesions, are amenable for the epilepsy surgery. Courtesy of Dr. Asano, the EEG, the neurophysiology director of Children's Hospital of Michigan, I have this slide which practically shows that after identifying the lesion with neuroimaging studies, here is presented the glucose hypometabolism of PET scan with the red color. After identifying through MRI, PET scan, video, EEGs, the areas generating seizures, the placement of intracranial electrodes takes place. Then the patients are followed with EEG recording for 2 to 5 days, where we try to identify more information about the seizures, the seizure focus, and the surrounding areas. Also, functional cortical mapping is done at that time to identify the sensory and motor cortex, and only then the removal of the seizure focus takes place. This is a case of a patient who had medically uncontrolled seizures. She had resection of the lesion which generated the seizures, and she was seizure-free for 12 months after surgery. Moving to vagus nerve stimulator, it is a palliative technique, and it involves electrode placed on the vagus nerve and a pulse stimuli from an under-the-skin placed stimulator. It is used in refractory type of epilepsy. Most studies about their efficacy are in adult patients, but there are some encouraging results in children with reduction in seizure frequency. Here is the illustration of the vagus nerve stimulator. On the left side of the anterior thorax is placed this pulse generator. Then the electrodes coiled around the vagus nerve are presented as well. 50% of the patients with VNS have a reduction of more than 50% of their seizures. On the other hand, less than 10% become seizure-free. VNS implies longer-term commitment than medication which do not work. About ketogenic diet, you're going to hear later in the day more in details, but briefly, it is a diet which involves moderate amount of protein and high fat combined with low carbohydrates. The mechanism of action is not fully understood. The role of the high ketone bodies have been demonstrated. The disadvantages is that patients might develop diarrhea, vitamin deficiency needs to be taken in consideration, and making diet acceptable, it's not always easy, especially when we are dealing with young children. The success rate is variable. The diet is safe but not risk-free, especially for patients who have inborn errors of metabolism. If we are wondering how the ketogenic diet can look on the table, it looks quite inviting. As you see on the left-hand side, they describe there the tomato-based pizzas, and on the right side, quite inviting menu as well. Other therapies, ACTH or adrenocorticotropic hormone has been used for treatment of infantile spasms, corticosteroids used in seizures and epilepsy syndromes which are having intense EEG abnormalities such as in Landau-Kleffner syndrome, and also for refractory type of epilepsies, intravenous immunoglobulins have been or are used. Quality of life issues. It is known that patients with epilepsy suffer a deterioration in quality of life. For children, school performance and cognitive function are affected. There are memory issues, attention, concentration issues, also a large number of learning disability among patients with epilepsy is known to be present and contributes to that. For adults, the loss of driving privileges, loss of independence, loss of work, which leads to financial insecurity, is what contributes to the loss of independence, and practically the loss of independence is the most socially disabling. So that families need to keep a balance in between concerns for safety and need for independence. With teenage issues, they need to be informed about driving issues, the state regulations for the driving, which differs from one state to another, and counseling for other issues such as puberty or dating needs to be offered as well. Quality of life issues, fear of when and where the next seizure will happen is a common problem with patients with epilepsy. The rate and the prevalence of depression is significantly higher in the patients with seizures. If in the general population is known to be around 16%, the mean prevalence for population with epilepsy is 29%. Oftentimes, anxiety and depression can coexist in the same patient. Bipolar disease is another important psychiatric comorbidity. In addition, suicide and suicide attempt, it's significantly higher compared to the general population, probably 3 to 4 times higher. Self-management behavior, keeping a seizure diary might be helpful to identify the frequency of seizures, to see if the trend of seizures is changing in any way after a change in medication. Identification and avoidance of triggers such as sleep deprivation, maybe photic stimulation or stresses can improve further management. Medication compliance, and I would add also compliance with follow-up, are important in really keeping a good track of what's going on with the seizures, how well they are controlled, and what other changes needs to be made to the medication to control them better. Good sleep habits and a generally balanced lifestyle have been advocated as helping as well, and stress management. I think that we are coming close to the end of this talk, and I have listed here the important resources with their internet addresses, and I think, at least for the families, and not only, even for professionals, very important sources for us, all of us. Thank you very much for your attention. Thank you.